Hello, everyone, again, and welcome to week 3. We're going to be talking about mood disorders. So, this week you'll be reading To Save Fitzpatrick, Chapter 8, Boland, Chapter 6, 7, and 25.3, and also reviewing your DSM 5 for bipolar and related disorders and depressive disorders. You'll have a training on Columbia suicide screening, um, and how to do that. And then obviously there's this lecture here. So, three topics we're going to cover today: major depression, bipolar disorder, and suicide. So, there are several different types of mood disorders. You see here major depressive disorder, and within major depressive disorder, you can have mild, moderate, severe, moderately severe. You could have severe with or without psychotic symptoms. So, be aware of that. You have bipolar 1 disorder, bipolar 2, cyclothymic disorder, substance induced mood disorders, a mood disorder due to a medical condition, dysthymic disorder, premenstrual dysphoric disorder. I have several women that I treat with this. Um, and note that seasonal affective disorder and postpartum depression are considered qualifiers of other major mood disorder diagnoses and do not necessarily stand on their own as a diagnosis in the DSM-5. So just be aware of that. Looking at the impact and prevalence, it's pretty alarming and statistics here. So up to 5 to 10% of the world's population suffers from a mood disorder at any given time. That's from the WHO. And in 2020, an estimated 21 million adults in the US had at least one major depressive episode, and that is 8.4% of US adults. And the prevalence of major depressive episodes was higher among females compared to males, and that's typical. Females tend to have higher rates of depression than males do. The WHO predicts it will only get worse. Mood disorders are a leading cause of disability worldwide. And then with each episode, the likelihood of recurrence increases significantly. So 50% chance after first episode, a 70% chance after a second episode, and then a 90% chance of recurrence after a third episode. So, what is mood and what is affect? You need to be able to differentiate this. This is, part of your mental status exam that you do. So, mood is how a person feels internally. So, you would ask them, "What's your mood today? How are you feeling?" "Oh, I feel down. I'm depressed," or I don't feel good. I feel hopeless. And then affect is how a person's feelings are expressed externally. So, you're observing that. Um, and watching for that. So mood does not equal affect. However, if affect and mood are not similar, they are considered incongruent. And this is clinically relevant phenomenon. And what do I mean by that if they're incongruent? Well, if they're saying they're down, depressed, and hopeless, but they're happy and they feel great, but they're saying they're real down, well, that would be mood incongruent. Um, so that's something that's very important to know too. So we're going to spend a few minutes talking about depression. What causes depression? Well, we know that there are deficiencies with serotonin, norepinephrine, and dopamine. So that's a chemical factor, right? There's genetic factors. We know that uh, higher rates of depression in those who have a first degree relative with that. There's inherited variances in alleles in the 5-HTTLPR may impact how we process stress. And there is also stress that can cause loss, grief, can cause depression, dysfunctional interpersonal relationships, trauma can all lead to depression. Hormonal imbalances, so folic acid metabolism. Estrogen doesn't always play well with GABA, glutamate, or monoamines. So we're going to look at the DSM-5. criteria for major depressive disorder. 5 or more symptoms for at least 2 weeks. Very important to know that. A depressed mood and or anhedonia, and at least 3 or 4 of the more of the following: unexplained weight gain or loss, increased or decreased sleep, psychomotor retardation or agitation, fatigue, anergia, feelings of worthlessness, guilt, or hopelessness, decreased concentration, focused or indecision, recurrent thoughts of death. And it causes significant dysfunction, and it's not explained by either acute stress, other mood disorder, substance use, or a medical disorder. So, how do you assess for depression? Well, again, like everything we are doing, we're meeting with a client, doing an interview, getting their chief complaint, doing it, taking their HPI, looking at the A's. Remember your A's: anhedonia, anergia, apathy, evolution, and mood, sleep, appetite, worthlessness, hopelessness, decreased concentration, thoughts of death, suicidal ideation. All very important. Words that people use to describe their depressed mood. They feel blah, irritated, empty. They can be silent, not say much, tearful, sad, alone, angry, vacant, hopeless. There are elements of the clinical history that are important. There's social history, recent breakup, a divorce, a job change, a recent move, substance use history, especially downers, opiates, alcohol, benzos, all contribute to depression. I have many patients, clients who are surprised when I share this with them. Family history, either diagnosed or suspected. Medical history, thyroid dysfunction. Very important that you guys understand that and always assess for that in your patients, especially a newly diagnosed patient, someone you're thinking with depression. You always want to rule out thyroid dysfunction or some other neuro disorder like multiple sclerosis, CVA, cardiac history. But again, I can't overemphasize the importance of a thyroid dysfunction and obtaining a good medical history as well. Past psychiatric history. What have you been diagnosed with in the past? Have they ever been diagnosed with depressive disorder or bipolar disorder or some other type of mood disorder? Then looking at a mental status exam for depression. So their appearance, are they disheveled? May not be well groomed. Generally, they don't care what they look like. Behavior, poor eye contact, psychomotor retardation, and energetic. Their mood is sad, angry, irritable, apathetic. The affect can be sad or flat. Speech is slow, could be low. Thought process typically within normal limits, but maybe slowed. Thought content is typically within normal limits, and perception, again, typically within normal limits. Cognition could be typically within normal limits, and we're not talking about severe depression with psychosis. Insight varies, can be fair to poor. To good. They may know they're depressed as well, and judgment may be impaired. So, my patient has major depressive disorder, but be mindful that it can coexist with anxiety disorders. Oftentimes, those two present together. And so, is it the anxiety that's causing someone to feel depressed, or is someone depressed and they also have anxiety? Personality disorders, substance use is a big problem. Schizophrenia, eating disorders, ADHD. Um, and so it does not coexist with bipolar disorder or schizoaffective disorders or other unipolar mood disorders. So you're going to have bipolar or unipolar depression. It's going to be one or the other. And some screening tools for depression. Your PHQ-9, Patient Health Questionnaire. I use this with every visit and every patient that I see. HAM-D, the Hamilton Depression Rating Scale. Beck Inventory Depression Scale. The Mood Disorder Questionnaire. That's a nice one for screening patients. And the QIDS, the Quick Inventory of Depressive Symptomatology. I have not really used that one, but that's available as well. Real life patient stories. So I want to talk about Gary. He's 62 years old, lost his wife of 40 years to COVID last week. Since her death, he has stayed at home, mostly laying in bed, sitting on the couch, staring into space. He's been sleeping fitfully and eating very little. Says he thinks about dying a lot because he doesn't know how to live without his wife. Now, is this major depression, though? Um, Again, looking at the timeline. Let's look at Samantha. Samantha's a 23-year-old who dropped out of college, reports feeling irritable, angry, and, quote, blah. Wanted to be a nurse, was a nursing student, but stopped going to class in her last semester because she says she just doesn't care about anything anymore. Sleep is poor, appetite is fair, denies any recent breakups, and denies any significant substance use. Could this be major depressive disorder, or could it be something else? So, treating major depressive disorder, you want to look at your STAR-D, evidence-based guidelines recommendations for the treatment of major depressive disorder. I've posted a nice link for you that has the evidence-based guidelines for treatment of various disorders. You want to know those like the back of your hand, especially when testing and treating patients, but definitely for testing as well. So steps 1 and 2, SSRI of choice. Again, giving it an adequate trial, going to the max dose. Try a second if the first med was unsuccessful, and you can also use an SNRI, Wellbutrin, bupropion, and mirtazapine. Step 3, consider thyroid supplementation, augmentation, or other antidepressant classes such as second generations, mood stabilizers. You have lithium, TCAs, MAOIs. And step 4, consider non-pharmacologic approaches. Neuromodulation, TMS, that's transmagnetic stimulation, and ECT. Ketamine is a pharmacologic approach. I apologize there. And they have really nice now. There's a nasal spray for ketamine. It's called Spravato. That looks like very promising for people with treatment-resistant depression. Some clinical nuggets. Again, as I've shared, psychotherapy at all stages, really, really important. I can't underestimate that, the importance of that. And always reconsider your diagnosis. Are we looking at depression or is it something else? Again, be mindful of those medical comorbidities or medical things that could look like depression but aren't depression. Um, Treat the symptoms and the underlying issues. Their sleep. Are they sleeping poorly, sleeping too much, anxiety, etc.? Um, be mindful of those things. So we're going to spend a few minutes now looking at bipolar disorder. Bipolar disorder, key findings. There's a nice center in the University of Michigan, the University of Michigan Prechter Bipolar Research Program. I put the link here if you're ever interested in looking that up, or you can do a Google search for the Prechter Bipolar Research Program. Migraines are 3.5 times more common in people with bipolar disorder. More people with bipolar disorder have a history of childhood trauma than those without. Remember those ACEs we talked about last week. Yeah, something to be mindful of again. And then people with bipolar disorder may have a diet higher in saturated fats. And this is interesting. This bipolar disorder has the highest rate of suicide among all mental health conditions. The rate is about 10 to 30 times higher in people living with bipolar disorder than in the general population. And suicide rate is higher in bipolar 2 than bipolar 1. Sorry, there's a typo there, but suicide rate is higher in bipolar 2 than bipolar 1. And there seems to be maybe two particular genes may increase susceptibility. I put those there for you, the CACNA1 and the ANK3. But remember, no one gene is going to be attributable to risk of developing bipolar disorder. There's multiple factors that can contribute to that. And two types of bipolar disorder. Excuse me, you have bipolar 1 disorder, um, episodes of depression and mania. Must have mania to be bipolar 1. Okay, can be episodic. Mania may include psychosis. All right, so very important to know that. And then bipolar 2 disorder, episodes of predominantly depression and hypomania. Again, can be episodic, no full mania, and no psychosis for bipolar 2. So know these two types. You will see these again. You will have patients with this. Very important to know how to uh, discern and differentiate these two types of disorders. So what is mania? Very important. It's a marked effect on functioning. If you have ever seen someone with mania, you will never forget it. Inflated self-esteem, grandiosity, decreased sleep. Remember, this is episodic. Hyperverbal, and when I say hyperverbal, they just do not stop talking. Flight of ideas, racing thoughts, easily distracted, and they engage in risky behavior. Remember, this is episodic. Symptoms last at least a week, and they're present most of the time, and not attributable to substance use or medications or some other medical disorder. And what is hypomania? Well, they're the same symptoms, less severe. Uh, Never any psychosis. Symptoms do not cause major effects on life functioning, and episodes last 4 days or less, and it's considered, quote, mania light. What bipolar disorder is not? I frequently have clients that tell me, I think I'm bipolar. Well, it's not moodiness, and they'll say because they're moody, or it's not a personality disorder, although they could have co-occurring, right? And it's not an adjective. It's not something that people use that you can use or throw around to describe yourself or how you're feeling. So I always try to educate the people I work with, the clients that I work with, about bipolar and not referring to themselves that way if that is truly not the case. Now, assessing for mania, you're looking at the chief complaint may or may not be relevant to symptoms. The HPI may be difficult to follow. Assess for sleep or oral intake, risky behaviors, substance use, increased risk associated with impaired judgment. Ask about caffeine. We always forget about that one. Very important. Medical history. Assess for recent infection, use of steroids. You need to know that for someone who has bipolar disorder, you do not want to ever give them steroids if at all possible. Now, listen, I get there may be some instances where they have to have it, but if they have bipolar disorder, that can put them into mania. They have bipolar 1, right? So do not do that, or make sure they aren't given that. And in fact, they may not know they have bipolar disorder and end up getting a steroid. I recently had a patient that happened to, and that would put them into mania. So looking at a mental status exam for someone with bipolar disorder, again, maybe disheveled, incongruent, bizarre. Their behavior could be hyperactive, restless, fidgety. Mood could be euphoric or irritable. Their affect can be expansive, labile, speech, rapid or pressured. Thought processes, tangential, flight of ideas. Thought content could be future-oriented, ruminating. Perception may be within normal limits, may have audiovisual hallucinations, delusions, paranoia. Um, Cognition typically can be within normal limits. and symptoms, unless their symptoms are severe, and their insight is usually impaired, their judgment is poor. Um, Also, remember their thought content could be suicidal as well. So you want to always assess for that. So, is it bipolar disorder? Lifelong chronic depression has periods of euphoria for a few days, about once a year. Is that bipolar? And then lifelong chronic depression, periods of euthymia while on antidepressants. Well, remember, you don't want to give someone with bipolar disorder, bipolar 1, an SSRI alone, as that can induce mania. And sometimes we don't know that someone is bipolar until they're on an SSRI, and it can induce or put them into mania. I recently had a young man that happened to. He had no idea. He ended up as an inpatient for several days until that resolved, but he's doing well now. Chronic insomnia, risky sexual behaviors for 3 years following a sexual assault. Is that bipolar, or is that something else? History of schizophrenia with periods of particularly severe depressive symptoms. Is that bipolar? And then periods of euphoria occurring nearly every spring, lasting 2 to 3 weeks. So just some things to think about on that. Treating bipolar disorder. First line is mood stabilizers, anticonvulsant, second generation antipsychotics. Remember, lithium is the gold standard. Difficult to manage. Patients have to be compliant with lifestyle modifications and risk in overdose. And also, you know, being mindful that there's medications they just can't have while they're on lithium, such as nonsteroidal anti-inflammatories and others. So again, it is difficult to manage, but it is the gold standard and very effective. And use of antidepressants. A patient can be on an antidepressant, but it must be used with caution, and they need to be stabilized first on these other medications. But it is possible to have them on an antidepressant. One thing that I didn't put in here that I want to caution everyone about, particularly for someone with bipolar 1 disorder, you do not want to have them, if at all possible, on a stimulant or non-stimulant medication for the treatment that we use for the treatment of ADHD, as this can also induce psychosis or mania. So again, very important. You do not want to have a patient with bipolar 1 disorder, um, or unless they're very, very well managed um, and you are comfortable. But I'd be cautious and with using a stimulant or non-stimulant, as this can induce some mania or psychosis. Okay. Again, your CANMET guidelines for treating bipolar disorder. That's the Canadian Network for Mood and Anxiety Treatments. That's a great resource. Acute mania, they have recommendations here for you. Acute bipolar depression, um, there's some nice recommendations here for you as well. And then maintenance um, talks about all of that to help you with their treatment. So you're not alone here in how to manage these patients. Let's talk about suicide, another um, problem that we will encounter. You encounter as you're working with clients, and some statistics here. So I was a little shocked when I was putting this together this week for you, but one death worldwide every 40 seconds. That's from the WHO. The rate of suicide is highest in middle-aged white men, and it's the 12th leading cause of death nationwide. There were nearly 2 times as many suicides in the United States as there were homicides. Very sad. 77% of global suicides occur in low and middle income countries. And in 2020, suicide was among the top 9 leading causes of death for people ages 10 to 64. And suicide was the second leading cause of death for people ages 10 to 14, and 25 to 34. Very sobering statistics. You should know about the new crisis suicide prevention lifeline, 988. It's like instead of 911, we have 988 now that people can call and get help. Give that to all of your clients. I always tell them I have it on my discharge note. Automatically it prints out. So 988, suicide and crisis lifeline. Some risk factors for about suicide, modifiable risk factors, loneliness, right? So these are things they can do to modify. So maybe helping connect them with an organization, churches, different places to help with that. Access to treatment, pain, and then access to means. Those are modifiable risk factors. Non-modifiable risk factors are age and gender, underlying mental illness, physical illness, like a traumatic brain injury, close family, friends who've completed suicide. We know that there are higher risks for those who have a relative who's completed suicide. And then food for thought. Suicide is not a crime. And consider that in our terminology. We often treat it as a crime. So, looking at some myths of suicide, if a person really wants to kill themselves, nothing will stop them. True or false? Well, that's false. We can oftentimes intervene. And then there's not a single suicide method that is guaranteed to be lethal. Again, that's false. Even if someone takes a gun to their head, they may live through it. Uh, I've seen that. It's not pretty, but and their life will never be the same, but that is not guaranteed that they will die. So some resources here for you. The suicide resources for you are the American Foundation for Suicide Prevention. Great resource. Great website. I encourage you to all check it out. And then we used to have Suicide Prevention Lifeline here, but that has switched again to 988 for Suicide Crisis and Lifeline. Again, 988, which took place from the Suicide Prevention Lifeline. Next week, we're going to be looking at thought disorders. So you have your readings here. There'll be a TED Talk for you, and lecture and discussion board. And again, I wish you guys a great week.